Good morning. Today I'll be discussing an early reliable diagnostic biomarker for non-arteritic anterior ischemic optic neuropathy. NAION is a type of optic neuropathy in which optic nerve head experiences partial or complete infarction due to occlusion of short posterior ciliary arteries. It is the most common acute optic neuropathy in 50-year-old and older population. In one Indian study, it was identified as the second most prevalent etiology of acute optic neuropathies following demyelinating optic neuritis. OCT is a non-invasive imaging technique with high resolution which offers an objective approach for evaluating individual retinal layers. It depicts the most evident finding of axonal loss as thinning of nerve fiber layer in NAION. But retinal nerve fiber thinning can only be detected on OCT subsequent to the resolution of optic disc edema and RNFL thickening, a process that may require up to months according to previous studies. Consequently, RNFL thinning could not be utilized to establish diagnosis in early phase following the onset of symptoms. Around 50% of the retinal ganglion cells are situated in the human macular region, and NAION often impacts the papillomacular bundle. Investigating the macular region using GC-IPL could potentially be beneficial in identifying early structural abnormalities. So the aim of our study was to study the ganglion cell layer and inner plexiform layer thickness in patients of NAION. We did a descriptive observational cross-sectional study in our tertiary care hospital in New Delhi with 20 patients, and we involved both the eyes of the patients. Inclusion criteria was patients with unilateral NAION who presented within 15 days of onset of symptoms, and we excluded all the patients who presented after 15 days of onset of symptoms bilateral optic neuropathy or associated giant cell arteritis. Then we went for complete evaluation of each patient, including complete ocular examination, visual acuity, color vision, contrast pupil assessment, and dilated fundus examination. Then we went for visual fields assessment by Humphrey Field Analyzer. We also went for ESR and CRP evaluation to rule out any arteritic cause. Then we went for 3D segmentation to compute GC-IPL thickness on STOCT. Our results showed that mean age of the patients who presented to us was 45 years. 60% of them was comprised by males. The average day of presentation we saw was 12 days. There was a significant difference in the visual acuity of the NAION eye and the fellow eye. The mean deviation of visual fields in NAION was minus 12.05 decibels, and the fellow eye was 0.29 decibels. Then we compared the mean GC-IPL thickness of NAION eye and the fellow eye, and it turned out to be having a significant difference with p-value less than 0.001. This is a scatter plot showing association between visual acuity and mean GC-IPL thickness in NAION patients. There was a moderate negative correlation between the visual acuity and mean GC-IPL, and this correlation was statistically significant. This is a scatter plot depicting association between visual fields and mean GC-IPL thickening, and it showed a very strong positive correlation, and this correlation was statistically significant. Our study showed that NAION eye showed a significant reduction in mean GCL-IPL thickness compared to the fellow eye within 15 days of disease onset. GCL-IPL thinning showed significant correlation with visual acuity reduction and visual field defects. Our study was comparable with Keller et al. And Coppersmith et al. They observed a substantial decrease in GCL-IPL thickness in comparison with the fellow eye. Agarwal et al. Revealed that GCC loss maps showed excellent point-to-point correspondence with visual field loss in most of the altitudinal visual field loss cases. Various studies have been conducted to depict GCL-IPL thinning in chronic NAION cases, but acute changes in GCL-IPL thicknesses have been studied only by Dom Pablo et al., which demonstrated that a substantial reduction in GC-IPL minimum was found as early as 2.2 days following the onset of symptoms. Conclusion. So we already know that there are a number of studies which have reported thinning of RNFL and GCL-IPL in chronic cases, but we have emphasized on early changes in GCL-IPL thickness and its correlation with visual dysfunction. An attempt was made to establish GCL-IPL thickness as an early biomarker in NAION. The limitation of our study was that it was a cross-sectional design. A longitudinal study design and a larger sample size can provide additional data in establishing the correlation between the GCL-IPL thickness, visual dysfunction, and NAION. Thank you.
Also in Harris, blood supply of the optic nerve head. We know optic nerve head is supplied by the posterior ciliary artery according to Sosik Harry. Posterior ciliary is a branch of optic artery which arises from the first digit of the nerve.
Yes.
The filling of the blood in the posterior ciliary artery depends upon the difference of the interval from patient to patient. So, if the deficiency in the blood supply of the posterior artery does not produce changes in the choroid, but in the epiphyseal choroid, which is characterized by the cavernous degeneration of the optic. So, according to Harry, if the IOP is less, the perfusion pressure is better, so there is better filling.
Yes.
Harry, who has done a lot of
Yes, yes. So
circulation and fundus fluorescein angiography.
true, but the study was not related to the perfusion. So yes, of course, Harry's work was landmark both for all aspects of ischemic neuropathy, particularly trying to understand the etiology.
Blood supply of the optic nerve.
Yeah, truly, absolutely, especially using fluorescein angiography to understand the disc perfusion. Yes, I think the major shortcoming of your study is that you're not followed up the patient, because it would be a useful tool to prognosticate, because that is one thing that we still lack to be able to. Yeah, so while it is correlating with poor visual function at the time of presentation, whether it correlates well with the final visual acuity is a more important question
Yes.
to answer, rather than just but yes, interesting. We hope that you will get a chance to follow up these patients and come out with
I'm following
better.
up those patients
Great.
like that as well.
Yeah, so that's what we need to probably understand, that like the longitudinal field defects, the ischemia leading to the optic neuropathy, it's not just confined to the NON only. Now we have a lot of atypical optic neuritis which are presenting almost like that, especially the MOG and all, and the NMO which really leads to a lot of ischemia of the optic nerve. So to really label this as a diagnostic biomarker, I mean, it may not be exclusively confined to NIN only.
Yes.
So essentially, it remains a combination of both clinical as well as the the investigative modalities, which may help you reach a complete diagnosis.
Yes.
Okay, so that's why we cannot just label it just exclusively and like that.
Sure.
But nice work.